started a little bit with COVID and outreach that we had for vaccine hesitancy and vaccine education, and also just in general COVID education. And we realized that there were health discrepancies out there, and there were areas that there was also a lack of trust in the mainstream medical delivery system. We realized it wasn't just the COVID, it wasn't just vaccines. There was a lot of other trust issues there. And if we are going to try and help the community and help with health disparities, we are going to have to develop relationships. And we realized, and I realized, we're going to have to put models of care in the communities itself. Transportation, social determinants, there's a lot of barriers to getting health care in some of these areas, and putting the care where it needed to be in the neighborhoods was a key aspect of what we were putting together. And this was actually in partnership too, in conversations with the civic leaders in Berkeley and with the head of the Union Mission, which is our homeless shelter, and to really see what they wanted and how we could help them with this delivering health care to their either communities or in case of the homeless shelter to their guests. We found in the case of the homeless shelter, for example, that putting a clinic in the homeless shelter made the most sense. And we did that. From day one, that just took off. The patients that were there just got out of the hospital or had medical conditions and couldn't get their prescriptions filled. They came to see us right away. Most of the care that these patients receive is from the ED. I'll give you an example. There was one patient had 164 ED visits over the past 15 years with a few hospitalizations, but no primary care visits at all. This patient needed medications refilled, but he also needed a medical home. He needed some place that he can go and follow up with. When we started a medication or adjusted a medication, he could come back to see us at the Union Mission, and we got him under good control. And I'd like to report that he hasn't been back to the emergency room. Berkeley has kind of been considered a health desert, and our focus is on uninsured and the Medicaid population here. But we see walk-ins, we'll see anybody that comes in. I've reached out to the local emergency rooms in this area and their leaders and the hospital leaders to tell them that, hey, we'll be happy to see your ED follow-ups, your hospital follow-ups. And then the last model of care that we do is the van. Traditionally, vans would be used for community events. You do vaccines there, you do health screenings, blood pressure checks, diabetes checks, maybe answer a few questions. And we use our van for that, but we've decided mostly we want to have these vans that give continuity of care. So we go to certain neighborhoods. We found neighborhoods that have, again, a high need for health care, and we'll take the van there on a regular basis and see patients. In our van, we can draw blood, we can do physical exams, we can prescribe medications. It's been very rewarding, not just for myself, but for the whole team that has put this together. The staff is really going out of their way to help.
This team effort has really taken root within the organization and externally, being able to build the trust with the leaders in these various organizations, whether it's the Union Mission or our food banks. We've also been able to offer wraparound services and connect people to different social supports through the network that we're building. And so what started through our many years of philanthropy and grant making has really lended itself for us to have these relationships where we can call and ask questions and really make something come to life that maybe wouldn't have existed before.